Level 1, the pre-med. You're 18. You told your mom you want to be a doctor. She asked what kind. You said you want to work with kids. She nodded, proud tears already forming. You told her specifically you want to work with kids who have cancer. She stopped nodding. Your dad Googled pediatric oncologist salary. He seemed satisfied. Then you told him about the cancer part. He Googled again. He has not spoken since. You're at Johns Hopkins University. Pre-med track. Biology, chemistry, organic chemistry, and a physics class that seems to exist for no purpose other than to remove joy from your life. Your GPA needs to stay above 3.7 to even look. Add a medical school application. Not to get in. To look. You study in the library every night. You sit next to a girl named Chen who color codes her notes by organ system, then color codes the color coding with a second set of colors. You decide not to sit near Chen. The MCAT is 7.5 hours. Biology, chemistry, psychology, critical analysis. Graded out of 528, the average. Score of students who get into medical school is 511. You need to be above average just to be considered average. You score a 506 on your first practice test. 6 months of Anki flashcards, Khan Academy, and UWorld question banks later, you score a 517. You apply to 24 medical schools. You get into 2. You call your mom. She cries. Your dad Googles, is 2 medical schools enough? He doesn't speak. He nods once. His version of a standing ovation. Level 2, the medical student, years 1 and 2. You're 22. You are now a medical student. Technically, mostly you are a person who memorizes things. The first 2 years are preclinical. No patients, just classrooms, anatomy labs, and the slow understanding that the human body is extraordinarily complicated and you are expected to understand all of it. In spring of year 1, you reach pathology. The neoplasia block. Cancer, then not as a word on a TV screen, but as a mechanism. A cellular process. A thing that happens at the level of a gene making a copy of itself incorrectly. Over and over until the copy becomes a problem. Then you reach the pediatric section. You stop. In the United States, approximately 15,000 children under the age of 19 are diagnosed with cancer every year. The two most common, leukemia, then brain tumors, then neuroblastoma, then Wilms tumor, a cancer of the kidney that almost exclusively affects children under 5. You sit with that sentence, a cancer that almost exclusively affects children under 5. You move to the next slide. In 1960, the childhood cancer survival rate was less than 10%. Today, the overall survival rate is approximately 85%. The improvement is almost entirely due to clinical trials, protocol-based treatment, and the pediatric oncologist who designed and ran them over 60 years. You write down 85%. You stare at it, then you think about what the other 15% means. You move to the next slide. Step 1, pass. You do not celebrate. You start studying for the next thing. This is the metabolism of medical school. There is no finish line. There is only the next threshold. Level 3, the medical student, clinical years, year 24, clinical rotations. This is where you finally meet patients. You rotate through surgery, internal medicine, obstetrics, psychiatry, family medicine. You are the lowest person in every room. Your job is to show up, learn, and not break anything. Your pediatrics rotation is in October of 3rd year. Week 3, the Pediatric Oncology ward. The floor is different from anywhere else in the hospital. There are drawings taped to the walls. Children have decorated their own room doors. One door has a hand-drawn sign in red marker that says, "Enter if you dare." A 7-year-old named Maya made it. She has acute lymphoblastic leukemia, ALL. She has been in treatment for 4 months. Her hair is mostly gone. She is playing Go Fish with her mom when you walk in to present the morning. Case. She beats you in 3 rounds. You did not let her win. She is simply better at Go Fish than you are. The attending on the ward is Dr. Mehta. She has been a pediatric oncologist for 19 years. She has a way of sitting with families that you will spend the rest of your career trying to understand. She does not stand at the foot of the bed. She pulls a chair to eye level. She listens completely before she speaks. When she speaks, she's entirely honest and entirely kind simultaneously. You have not yet figured out how both things fit in the same sentence. You watch her do it for 3 weeks. On your last day of the rotation, you pass Maya in the hallway in regular clothes. She is being discharged. Remission. Her mom is crying. Maya is holding a balloon. She sees you. She points. She says, "I still beat you at Go Fish." You drive home. You sit in your car in the parking lot for a while. You apply to Pediatrics residency. Level 4, the pediatric intern. Your 26 intern year, first year of residency. Pediatric residency has a specific difficulty that other residencies don't prepare you for. Children are not small adults. Normal ranges for heart rate, respiratory rate, blood pressure, all age dependent. A heart rate of 160 is a medical emergency in an adult. In a 2-month-old, that's Tuesday afternoon. You carry 2 sets of normal values in your head at all times, and the sets change as the child grows. You work 80 hours a week officially. Your attending is Dr. Osei, who asks questions the way some people do sit-ups. Constantly, without warning, and without any visible sign of tiring. If he asks you something you don't know, the answer is never, I don't know. The answer is, I'll find out and have it to you in 10 minutes. You learn this on day 2. You spend 6 weeks on the oncology service, 14 active patients, 3 of them are under 2 years old. There is a 5-year-old on the floor named Sarah. She has DIPG, diffuse intrinsic pontine glioma, a tumor in the key brainstem, inoperable. There is no effective treatment that changes the outcome. The standard of care is radiation, which slows the progression but does not stop it. Median survival from diagnosis, 9 months. Sarah is 7 months post-diagnosis. She comes in for symptom management. She has a stuffed rabbit named Gerald. She asks you, with complete seriousness, if Gerald is allowed to have a hospital bracelet too. You make Gerald a bracelet from a piece of medical tape and write his name on it in marker. Sarah shows her mom. Her mom looks at you over the top of Sarah's head and mouths 2 words without making a. Sarah dies 8 weeks later. You present at rounds the next morning. You know everything about every patient on the list. Dr. Osei asks you. Nothing about how you are doing. That is the contract of residency. You learn it. You hold it. You find somewhere else to put the weight of it. It takes a while to find the right place. Most of you will always be finding it. Level 5, the junior resident. You're 28. You now supervise the interns. Someone looks to you for guidance. This is thrilling and terrifying in approximately equal measure, mostly terrifying. Your clinical skills are sharper. You can place an IV in a difficult vein on a toddler. You can read a bone marrow biopsy result without letting your face change before you've processed what it means. You have delivered bad news to a family and learned how to stay in the room after you deliver it. That last skill takes longer than any procedure. The hardest conversations are not the ones where you tell a family their child has cancer for the first time. The hardest ones are where you tell a family that it has come back. A family that has already survived the diagnosis, survived the treatment, survived the exhale of thinking it was over, and now you are sitting with them again. And the word relapse is in the room and you watch something in them close. Dr. Mehta told you once, don't look at the floor when the news lands. Stay with them. She was right. It is the only right thing you can do in those moments, and it is genuinely hard to do every time. The survival rates are better than most people think. The most common childhood cancer has an overall 5-year survival rate of approximately 94% with treatment. Most of your patients get better. Most of them go home. Most of them grow up. You keep that number somewhere you can reach it. You need to be able to reach it. Level 6, the senior resident. You're 30. You apply for Pediatric Oncology Fellowship. There are 56 fellowship training programs in the United States, approximately 85 positions per year. It is competitive in the specific way things are competitive when you have spent 6 years preparing for them and there are still fewer spots than people who want them. You write your personal statement. You write about October of 3rd year, about the Pediatric Oncology ward, about Go Fish. You write about learning that medicine can extend a life and that extending a life is not the only thing you offer a patient. You match at Children's Hospital of Philadelphia. The week before you leave, you check Maya's chart. She's been in remission for 5 years. 5 years in pediatric. All is the threshold that oncologists consider a statistical cure. She aged out of the pediatric ward 14 months ago. She is now being followed in the adult survivorship clinic. She is 17 years old. You read that twice. Level 7, the fellow, year 1. You're 31. Fellowship. Pediatric hematology-oncology training is 3 years. The first year is the year you learn that everything you knew was the foundation and not the structure. You learn to read pathology reports the way a translator reads a text, not just the words, but what the words are, doing and what they imply about what comes next. You learn the COG protocols, the Children's Oncology Group, enrolls more children in cancer clinical trials than any organization in the world. Most pediatric cancer treatment is Protocol driven and trial enrolled. You are not giving a child a drug, you are giving a child a drug and generating data that will improve survival for the child diagnosed 5 years from now. You are given your first patient as primary fellow, a 4-year-old named James, newly diagnosed neuroblastoma, high risk, metastatic. The tumor has already spread to the bone marrow. Treatment protocol: 6 rounds of induction chemotherapy, surgery to remove the primary tumor, high dose, chemotherapy with autologous stem cell rescue, radiation, then 12 months of immunotherapy, total treatment. Duration: approximately 18 months. You sit with James's parents on a Tuesday evening and go through the protocol. His dad has a notebook. He takes notes on every word. His mom holds James's hand. James is eating a fruit cup and is paying attention to neither of you. You explain each phase. You explain the side effects. You explain the goals. You tell them that the 5-year survival rate for high-risk neuroblastoma is approximately 50%. His dad stops writing. You stay in the room. You wait. He looks up and asks, "What do we do first?" You tell him, "Level 8, the fellow, years 2 and 3. You're 33. Your second and third years are heavier and clearer at the same time. You run your own clinic days. You manage your own patient panel. You are the one they call on the weekend. You are the one who reviews the scan results at 11 p.m. and calls the family before they come in for their appointment. So they are not sitting in a waiting room holding a question they don't have the answer to yet. You develop a practice, not yet a style, but a practice, a way of being in the room. You learn that children process information differently from their parents. Children live closer to the present tense. They want to know if the treatment will hurt. They want to know if they can still go to school. They want to know if Gerald, or whatever they have brought with them, is allowed to stay. The answer is always yes. Gerald always stays. You see James at month 15. His scans are clean. Bone marrow biopsy, negative. He is in remission. He is also 5 years old and completely uninterested in you. He is interested in a toy truck he has brought to the appointment. You ask him how he is feeling. He tells you the truck goes very fast. You agree that this is important information. His dad shakes your hand after the appointment. He still has his notebook. He has brought it to every appointment. He wanted to understand everything as it was happening. He says he understood most of it. He didn't understand the 50%. You tell him you think about that number carefully, that you hold it with both hands, that it means something to you, that James is on the right side of it. His dad nods. He doesn't speak. You have learned by now that sometimes that is the review. Level 9, the attending. You're 34, Dr. Ginza, attending Pediatric Oncologist. Your name is on the door. You have your own clinic, your own patients, your own fellows who watch you the way you once watched Dr. Mehta, trying to reverse engineer how honesty and kindness fit in the same sentence at the same time. You take the hardest referrals, the relapses, the rare diagnoses, the families who have already been seen somewhere else and been told there are no further options. There are almost always more options. Not always more curative options, but always more options. And the difference matters. You start a survivorship clinic. Late effects of childhood cancer treatment are significant and chronically under-recognized. Certain chemotherapy agents increase the risk of heart failure in a patient's 30s. Cranial. Radiation can affect growth and cognition in ways that don't appear for years. A child who survives cancer is not finished with medicine. They need to be followed. You follow them. You have 290 active patients. You know most of them by name without opening the chart first. One of them is a 17-year-old named Maya. She is transitioning to the adult survivorship clinic. She comes for her last pediatric appointment. She is applying to university. She wants to study biology. She wants to be a doctor. She looks at you when she says that last part. You don't say anything for a moment. Then you say, "What kind?" She says she doesn't know yet. You tell her she has time to figure it out. Level 10, the division chief. You're 52. You run the Division of Pediatric Oncology at Children's Hospital of Philadelphia. Your CV is 41 pages, 203 peer-reviewed publications. You have treated over 2,400 children with cancer. Approximately 2,000 of them are alive. You have done the arithmetic. You have sat with the arithmetic. You know what 400 means. You know their names. You do not say them often. You do not say them never. You have trained 23 fellows who are now attending pediatric oncologists across the country. 2 of them run their own divisions. One of them, Dr. Reyes at Stanford, just published trial data on a CAR T-cell therapy combination. For relapse ALL, showing a 47% complete response rate in a patient population that previously had almost no doubted options. You read the paper on a Wednesday night, you text her one word. Yes? She texts back 4 words. I had good teachers. You sit with that for a while. You still run clinic 2 days a week. The cases you keep for yourself are the ones the fellows describe as no good. Options. You still don't use that phrase. You use insufficient information. You use insufficient imagination. You have spent 30 years working on both. James is 22. He sends you a photo every year on the anniversary of his first clear scan. In the first photo, he is 5 years old, holding the truck, squinting. In the last photo, he is standing in front of a university building, backpack on, squinting into the sun in the exact same way. He texts the same message every year. Still here. 2 words, same words, every year. You have never needed more. Closing. You chose the specialty where your patients are the youngest and the stakes are the highest, where you tell a parent that their child has cancer and then you sit in the same chair the following Tuesday and tell them what you're going to do about it, where you read scan results at 11 p.m. so a family doesn't have to wait, where the fruit cup matters, where the truck matters, where Gerald the rabbit gets a hospital bracelet, where 85% means something profound and the other 15% means something you carry. Not as a failure, but as the cost of the work and the reason the work continues. Comment below which career you want Genza to rank next. Subscribe, because we drop a new one every week. And the next career is one where your shift never ends. We'll see you then.